Assalamualaikum to all audience and good day to everyone. My name is Hafiz. I'm one of the nephrologists in UMMC and I'm going to present a topic on CKD management, anything new. So these are the outline of my topic today. So I'm going to briefly talk about 3 new guidelines that just coming out last year and also some new RCTs that are relevant to the field of nephrology. First of all, there's a new study in Malaysia describing the prevalence of CKD in Malaysia. So previously, we know in 2013, the publication showed that the CKD prevalence was only 9%. Now, with the latest study, we know that over a period of, 7 years or 6 years, the prevalence of CKD in Malaysia has shot up to 15%. And the overall prevalence in the world is between 10 to 20%. So we are on the rising. This is consistent with the prevalence of diabetes and hypertension in Malaysia based on the 2019 NHMS study, whereby the diabetes prevalence was 18.3%, while the prevalence of hypertension was 30%. Now, the first medication that I'm going to talk about is about SGLT-2 inhibitor. This is originally a diabetes medication. And we know for diabetes, it has been a long time where we don't have much of a new medication that can change the horizon of the medicine until we have this medication. So SGLT2 comes from the bark of an apple tree, and it has been used to treat diabetes traditionally in certain countries until it has been commercialized and make do and redo of a new molecular structure. And now we have plenty of SGLT2 inhibitor. It works by arterial vasoconstriction to reduce intraglomerular hypertension. And so far, even in Malaysia, we have at least 4 or 5 SGLT2 inhibitor, and they're all, to a certain extent, working around the same. The trials of SGLT2 inhibitor focus on the cardiovascular outcome, and almost all the trials shows that the SGLT2 inhibitor did work in reducing cardiovascular outcome. So for example, in these slides, you can see the average reduction of hospitalization for heart failure is roughly about 30 to 35%. And the risk reduction for cardiovascular death is about 20 to 30%, right? Now, this is also, apart from the cardiovascular outcome, they also look at the renal outcome. And it's more surprising that the renal outcome for SGLT2 inhibitor is much more than the cardiovascular outcome. So for example, the DECLARE-TIMI, the CANVAS, EMPA-REG, they all shows kidney outcome reduction of 40%. So that means if you're taking this medicine compared to those who are not taking this medicine, you have a 40% less chance of developing end-stage kidney disease. There's also newer study like CREDENCE and DAPA-CKD, which in DAPA-CKD, they employ patient who's not even diabetes and do have CKD, and it still shows that this SGLT2 inhibitor works by delaying the progression of a kidney disease. So it is really good to have a new medicine that can do all this. But just beware that there are certain things about SGLT2 inhibitor, if we decide to use it, that we have to be aware of. For example, the initial dip after we use the SGLT2 inhibitor, it can be quite prominent. For example, you can see these slides where I circle it. So almost all studies with SGLT2 inhibitor, they will show this dip. That means if you see that the GFR is reducing or the creatinine is rising after you start the SGLT2 inhibitor, do not be too reactive to stop it, because this is a natural phenomenon, and you can see after a couple of months, then this SGLT2 inhibitor will be much better than the placebo. Other side effect of SGLT2 inhibitor includes volume depletion, because you are going to get rid of the sugar through your urine, and that makes you more prone to get fungal infection or mycotic infection around the area. Now, we have another exciting medicine for diabetes, what we call GLP-1 agonist. Now, the result of this GLP-1 agonist is not as pronounced as the SGLT-2 inhibitor, but the studies are coming in. It has been known as a magic pen nowadays because some people are using this to lose weight. For example, in recent publication in NEGM, February 2021, when they used this for 1.5 years, the average weight loss is about 13 kilos. Okay, but it has not been approved by the FDA for this indication yet. So we have a lot of GLP-1 agonists. Most of them are injectable once a day or once a week. And the initial clue, it shows that these GLP-1 perhaps also are going to give good kidney-related outcome. However, in this meta-analysis as well, it shows a good kidney outcome. But it is not at par with SGLT-2 inhibitor because they don't have yet study that targeted renal outcomes specifically. So we have to wait for those studies, which are ongoing. We also have another medicine, which is older, that has been tried and tested to see whether it works on the kidney as well. Although it's good because it's quite neutral, it doesn't cause much of a dip of the creatinine, but unfortunately, it hasn't shown any beneficial kidney outcome. Hence, the KDIGO 2020 guidelines has come up with the guidelines, and they actually put the metformin, which is an old medicine for the diabetes, and the SGLT-2 inhibitor at par with each other. So that means that for those who have a kidney problem, you should be on these two, regardless whether you're on diabetes or not having diabetes. Nowadays, anyway. And then you can use GLP-1 agonist because it promotes weight loss and also may have kidney-related outcome before we try to use other medicine. Now, for the past couple of years as well, people have been talking about sodium bicarb that may reduce the progression of a kidney disease. And recently, in 2019, the UBI trial has shown that supplementing sodium bicarb to the patient who has slightly low bicarbonate level will actually delay the progression of a kidney disease. And this is good because this is one of the biggest trials of sodium bicarb that we have. So that gave more strength to the idea that we should correct the acidosis in somebody with CKD. Because of these sodium bicarb trials, then the KDOQI nutrition guideline, we rarely have nutrition guideline under medical, but this KDOQI nutrition guideline says that we should try to supplement, or we recommend that we should reduce the net acid production by giving sodium bicarb supplementation. And then I think I put this one up because a couple of years ago, there's a discussion about should we go very low protein diet supplemented with a keto analog, or should we go with a low protein diet? So they have come up with a guideline saying that you can either go with a low protein diet, which is 0.5 to 0.6 kilogram per day, gram per kilogram per day, or you can go very low and you supplement with a keto analog. Important for me to say that this is limited to non-diabetes only because the way the trial has been done. To the next guideline that we have, which was just published, I think, last week or a couple of days ago, was KDIGO hypertension in CKD. So the last KDIGO guideline on hypertension was in 2012. And I remember 2018 when there are a lot of guidelines coming out, the Malaysian guideline, the ESC guideline, the AHA guideline, the US guideline. They all talk about hypertension because there's one particular trial at that time called SPRINT, which make people confused because all this while we know that for CKD patient or for general population, 130 perhaps is not so bad, or less than 140 is not so bad. But based on that particular trial, driving the blood pressure in non-diabetes patient to less than 120 is much better. They have a cardiovascular outcome benefit compared to those who are driving at less than 140. Hence, that's why at that particular moment, there's a lot of guidelines coming out trying to push for lower blood pressure target. And this is a summary. So you can see in 2017, ACC come out with a guideline. Malaysian, the last guideline was in 2018, ESC 2018, and there's a gap 3 years later when the KDIGO comes out with 2021 guideline. There's no new study. The KDIGO, the new guideline also talk about the SPRINT trials particularly. But in particular, the reason why the SPRINT trial can reduce the blood pressure that much because they actually do a standardized BP measurement. So basically, they do the BP without anybody in the room. They put the patient inside the room calmly and quietly, and then automatically check their blood pressure. So that's why we cannot compare the blood pressure in the SPRINT trial with our usual clinic trial where, you know, most patients will say, I just walk in from the parking to the clinic, and that's why my blood pressure is high. So we have to make sure if you want to follow the guideline of less than 120/80, we have to take the blood pressure in the standardized measurement. What is it, the standardized measurement? It's available in all kind of a book. So we have to prepare the patient, cannot drink alcohol, cannot smoke. Their patient has to sit down, fit down, and back to the chair. Rest for 5 minutes before you take the blood, and then you have to have a good technique for the blood pressure measurement, meaning that you have to use an appropriate cuff. You have to know, you know, if you're using an auscultation technique, then you have to know when you consider as systolic and when you consider as diastolic. At least take 2 measurements, because later you have to average reading of the two measurement, and then remember to provide the readings to the patient so that patient will have some idea of what the blood pressure is. So you can imagine this is not commonly done in our usual day-to-day clinic. And these were the target measures. So you can see from the beginning, we are not that strict with the blood pressure. 140/90, less than 140/90 will be fairly okay. Until towards the end, after the SPRINT trial, people have been going lower and lower. And you can see, despite using the similar evidence, KDIGO basically go with the SPRINT trial wholeheartedly and say, even the kidney patient, you should go for less than 120/80, which is surprising. The reason is, they also put a remark in there saying that, you know, this 120/80 business, there is a less certain in diabetes patient, because the trial exclude diabetes patient, less certain in advanced CKD because it can cause worsening of a kidney problem. There's a more AKI in somebody who's been having lower blood pressure, those who have a more significant proteinuria, baseline blood pressure which is not that high, as well as those who are young, less than 50 years old, or very old, more than 90 years old. So the KDIGO says that, hence, the recommendation of target SBP of less than 120 is based not on renal protective effect, because in that group there's more AKI, electrolyte abnormalities, but more of a cardioprotective effect and survival benefit. So if you want to look after your life and heart, you should drive your blood pressure less than 120/80. But if you are worried about your kidney, then perhaps 120/80 is a bit too low for you. There's also studies looking at the allopurinol. So a little bit of background on this. There's a move towards, you know, there's some studies before this saying that perhaps lowering uric acid may be good in somebody with CKD. And they try with febuxostat and they try with allopurinol until I think this study was published last year, where they have a large number of patients going on allopurinol versus placebo in CKD patient and try to see whether it works or not. Allopurinol does reduce the urate reduction. So it does reduce the uric acid level, but unfortunately it doesn't show any difference in delaying the CKD progression. Hence, based on this study, allopurinol does not help in, generally, it does not help in reducing CKD progression. And this study was done on the asymptomatic hyperuricemia. Now, there are other studies available for the past 1 or 2 years. They're very significant as a nephrology worldwide, but because in Malaysia we don't have this medicine yet, hence it's still not available in Malaysia. But I just mentioned it to you guys. So the first one is basically another treatment for anemia. So if you have read or if you have listened to our pharmacist lecture, she was talking about erythropoietin. So this is another medication where it's orally given. Can be taken by dialysis and non-dialysis patient, and it can increase the hemoglobin safely. So it's called hypoxia-inducible factor prolyl hydroxylase inhibitor. So technically meaning that, you know, you want to increase the level of HIF by preventing it from degraded, and this HIF will help with the increment of the erythropoietin and subsequently with the hemoglobin. It's still not licensed by FDA to be used, but it has been licensed in China and I think Japan as well for it to be used. So this is one of the example of recent trial showing that this HIF inhibitor or HIF pH inhibitor increase the hemoglobin without much of a problem. The potential advantage of this HIF inhibitor is that it increases the hemoglobin effectively. It's being taken orally, so no more injection like erythropoietin, as well as it helps with the regulation of iron metabolism, which does not happen with erythropoietin. Now, we also have another study that was, I think, published late last year. It is some kind of aldosterone antagonist like spironolactone, but it is non-steroidal, meaning that it does not have all those sexual side effects, such as gynecomastia, that you can see with spironolactone. So Finerenone is a new medicine. It was tried in CKD, and it shows that it reduces the kidney outcome, it reduces the cardiovascular outcome in a trial of 14,000 participants. So if this is coming to Malaysia, this will be another measure for us to use on the top of ACE inhibitor, on the top of SGLT to delay the progression of kidney disease. Now, for some local interests, so I think about last year, although this study was done a couple of years ago, so last year, somebody texted me asking me about this WhatsApp messaging that people have been sharing about the benefit of tocotrienol, which is a vitamin E available in palm oil, benefit of it to diabetes patient with diabetic kidney disease. So you can look at this into the YouTube. So the researcher was saying that, you know, they were commissioned by PORIM. PORIM is basically the research institute of the palm oil in Malaysia to do research on tocotrienol-rich vitamin E derived from palm oil. So just as a background, vitamin E has a tocophenol, which has been studied before in microhope study, and it shows there is no benefit of it. But now researchers are pushing tocotrienol, which is another more effective vitamin E. And it was explained in that video that in phase 2 trial, they have used this particular product, and it seems like it improved the eGFR. So this is a text I received. You know, people are buying this online, and it's not cheap. It's like 300 something per month. So I look into the PubMed, I look into the literature, and in fact there is phase 2 studies over 3-month period showing that this tocotrienol does somehow looks like it increases the GFR after 12 weeks, but after washout, and you know, the effect seems to be there, but it's not significant. You can see the p-value of 0.144. So this study only used about 50 participants, which is very small, and that's why it's called phase 2 study. Hence, as a Malaysian, I'm really excited because, you know, this is coming from Malaysia. We're using our own palm oil to see the effect of vitamin E tocotrienol on the CKD. As a researcher, we know that, you know, this is a small study still, so a lot more has to be done, especially the phase 3 trial. And we have seen as well something like this with the vitamin E, with the bordoxolone, with the folic acid in cardiovascular disease. When they do a small study, it looks significant, but when they go into the phase 3 trial, it became not significant anymore. Hence, as a summary, this was my slide previously when I talked about CKD management, anemia, bone, cardiovascular disease, dietary needs, and end-stage kidney disease preparation. But nowadays, with the new studies and with the new evidence, now I have to include, you know, the SGLT-2 inhibitor, the GLP-1 agonist, the Finerenone, the sodium bicarbonate, as well as the very low protein diet into our armamary of CKD progression. With that, thank you.